This is going to be the lecture over Chapter 11. We're going to start in on treatment planning and start looking at isodose distributions. So even though we can figure out what the dose is going to be on the central axis, we need to be able to describe the beam a little bit better than that. Even though we know what's going along the central axis, we need to be able to describe what's going on, say, a centimeter, 2 centimeters away from the central axis. Not only away from the central axis, but let's say in another dimension, say up, down, we need to be able to describe that particular type of distribution. So how do we go about doing that? We're going to look at something called isodose curves, which are going to be lines that are passing through points of equal dose. Isodose, same dose. So these are lines passing through points that have the same dose. And the curves are usually drawn at regular intervals of absorbed dose and may be expressed as a percentage of the dose at a reference point. They may be in absolute. So let's take a look at an isodose chart. Now, this is going to be from an older program. Most of the time in the programs that we see right now, we can see the same basic type of thing. It's just going to look a little different. That's all. So here on A, we're looking at source to surface distance type for cobalt beam. SSD is about 80. This is going to be the source to axis distance, or SAD, basically your isocenter type setup, where you're looking at the depth of isocenter, and you're looking at what it looks to be a 10 by 10 field. So that's what they're going to look like. Now, the question is, how are we going to change these things in order to produce what we want? Obviously, we can, shoot that into a phantom and we can kind of see what's going on there. But how does this work as far as shooting into a patient? So those are the kinds of questions that we're going to be looking at coming up here. So here are some general properties of isodose distributions. The dose at any depth is greatest along the central axis of the beam and gradually decreases towards the edge of the beam, with the exception of some Linac X-ray beams, which exhibit areas of high dose or horns near the surface in the periphery of the field. And these horns are created by the flattening filter, which is usually designed to overcompensate near the surface in order to obtain flat isodose curves at greater depths. I was hoping for an example somewhere out there, but I don't really see it. So near the edges of the beam or in the penumbra region, the dose decreases rapidly as a function of lateral distance from the beam axis. In other words, the width of the geometric penumbra, which exists both inside and outside the geometric boundaries of the beam, depend on the source size, distance from the source, and source to diaphragm distance. In other words, you start to see this kind of a rapid fall off on both sides here. That is going to be where you start to see the penumbra, where you're not seeing the full-on beam as you are out here. You're beginning to eclipse part of it, which is really what you're seeing over here. Near the beam edge, the fall off is not only caused by geometric penumbra, but also by reduced side scatter. In other words, you don't have as much exposure to scatter over on the sides. And therefore, the geometric penumbra is not the best measure of the sharpness near the edges. Instead, you might use physical penumbra. And it's usually defined as the lateral distance between two specified isodose curves at specified depth. Normally, I hear 80 and 20 used. In this particular case, they wrote 90. I'm not quite sure why. So outside the geometric limits of the beam and the penumbra, the dose variation is a result of side scatter from the field and both leakage and scatter from the collimator system. Beyond this collimator zone, the dose distribution is governed by the lateral scatter from the medium and leakage from the head in the machine, or therapeutic housing or source housing. So 11.2 shows the dose variation across the center of the field at a specified depth, which is, again, what we were looking at here. This representation of the beam is also known as the beam profile. It may be noted that the field size defined as the lateral distance between the 50% isodose lines. In other words, when this hits 50%, if your beam profile crosses at that point, then you can see the field edges. So to ensure that this agrees with the field size defined by the field defining light, you do a procedure called a beam alignment, and that's when the field defining light is made to coincide with the 50% isodose line. And another way of depicting dose variation across the field is to plot isodose curves in a plane perpendicular to the central axis. In other words, I kind of imagine this in this dimension. So this is more of what you would see in treatment planning. When you see it in a transverse view, you can kind of see where the isodose lines are, where they are around a particular target. So measurement of isodose curves, they're usually done by ion chambers, solid state detectors, or radiographic film. And an ion chamber is the most reliable method. It may be waterproof or covered by a thin plastic sleeve. And basically you've got a huge tank of water, and there are lots of different types of protocols that you have to run in order to be able to do this correctly. Not going to go into too much of that, because that goes on into the physics, really deep physics side of things, and that's not really where I want you to focus. You've got certain parameters here of isodose curves. You've got beam quality, source size, beam collimation, field size, SSD, the source to diaphragm distance, SDD, which is not really something I've seen used significantly. But these are the types of things that we will get into when we're starting to look at the monitor unit equation. What is a flattening filter-free Linac? That is more of a common option. It's a way that you can treat, and the characteristic is that it tends to go a lot faster. For example, linear accelerators designed only to deliver small fields, such as for radio surgery treatments, may not need a flattening filter in order to produce a beam that is sufficiently uniform. In other words, you're not making huge fields out of this, you're concentrating on the small field. Well, if the small field can be produced and is homogeneous without using a flattening filter, then why do it? For treatments with intensity modulated fields, IMRT, it is not necessary to flatten the beam prior to creating a variable intensity distribution. So as a result, manufacturers are beginning to offer the FFF options on modern linear accelerators, and you will see this going forward if you haven't seen it already. The largest difference between photon beams with and without flattening filters is going to be seen in the cross beam profiles. The beam profiles produced by using the FFF beams exhibit a central peak, which is more pronounced with greater energy and field size. Because the photon energy spectrum in this case varies only with off-axis distance, profile shapes from the FFF beams vary little with depth, and typically by only a few percent. And beams without a flattening filter offer some advantages. Without it, and without that flattening filter or attenuating filter, the incident photon fluence rate will increase by a factor of 2 or more. It'll actually, in many cases, I've seen this jump from normally what we use in our clinic, which is 500, although you can use 600. We've gotten the dose rates up to 1400. So that's why it's saying a factor of 2 or more. The increased photon fluence per incident electron results in a lower neutron contamination per monitor unit. Although for the lower photon energies used for radiosurgery and IMRT, this advantage is negligible. And then field size is one of the most important parameters in treatment planning. Dose coverage of the tumor requires a determination of appropriate field size. You got to have the biggest field size in order, or big enough field size in order to be able to treat the thing. It is something that you end up using dosimetrically. Basically, you can look at something geometrically by putting, a beam's eye view on, and you can see if you're covering it. But when you start shooting the beams in the planning system, you want to check to make sure that the isodose lines that you're producing are actually covering the thing. And so that's why it says this. If you're using a field smaller than 6 cm with a relatively large part of the field is in the penumbra region, you can start to have issues regarding underdosing. The isodose curves for small field sizes tend to be bell-shaped. So treatment planning with isodose curves should be mandatory for small field sizes. We don't ever use Cobalt 60, so we're not going to worry about that. Wedges. We don't need those stinking wedges. For wedges, what do we do? Now, in most cases, I don't think you guys are actually going to deal with physical wedges anymore. Was a time in which you had to put physical wedges in, and those wedges had certain advantages. The advantages is that you can put those suckers in and you can orient them in several different ways rather than the enhanced dynamic wedge that we use now, which is the non-physical wedge filter. The EDW, as it's referred to, only works, at least as far as with variant equipment is concerned, only works in the Y direction. So you can have it go one way or the other in the Y direction. If that doesn't suit your needs, then you end up having to turn the collimator 90 degrees to get the other direction. But the EDW will only work in the Y direction. Now, why would you need a wedge? In many cases, what you're looking at as far as a wedge, you are looking at something that needs to be able to tilt the isodose lines. In other words, you want to be able to have them slanted such that maybe one area can get more dose at the expense of another area. And this is what you're seeing here. You're seeing this is the toe, this is the heel of the wedge. And as you put this in there, what you're noticing is that you're shifting the dose. Think of it that way, that you're shifting the dose from this side over to this side. And the reason I say that is because your hotter isodose lines, the 120, 110, 190 or whatnot, are going deeper into this, whatever the object is that you're pointing it at, than they are over here. And depending on the wedge, you may end up needing maybe a steeper wedge, depending on what the circumstance is. So compensator, you can think of a wedge as a type of a compensator. And again, the non-physical wedge filter, as far as variant is concerned, is the electric dynamic wedge. Siemens has a virtual wedge. I've never really worked on a Siemens machine, so I can't really say that. I'm relying on what the book has. The other type of wedge that we have there, you can have the physical wedges, which are indeed just look like metal wedges that you put on a plate that you put in the beam. Now, with a lot of those, particularly a universal wedge, you have to watch to make sure that your field size isn't going above and beyond what those physical wedges have in terms of their coverage of the plate, because if you go too big, you'll start to have the sides there that won't have that same effect. What you will also see, and this is what we will get into with some of the problems coming up, is that a wedge will increase the number of monitor units that's going to be delivered as opposed to not having it. That is a pretty big deal. Okay, so you've got a wedge here. This is what the what an actual physical wedge would look like, and you can see kind of what I'm talking about when you get over here or over here. If you have field sizes that are too big, then the wedge can't help you in those particular areas. The wedge isodose angle is going to refer to the angle through which an isodose curve is tilted at the central ray of the beam at a specified depth. In other words, at a certain depth, this is going to make an angle with a straight line that goes across with it. Whatever that angle is what the wedge is actually referred to as. If that angle happened to be, let's go back to it, it happened to be 45 degrees with respect to this angle here, then this would be a 45-degree wedge. If it were 30 degrees, oh, there it is right there. If it were 30 degrees, this would be referred to as a 30-degree wedge. Now, there are going to be wedge factors that go along with this. Remember what I said about increasing the number of monitor units? Well, this plays into that. The increase in the number of monitor units comes from the fact that your wedge is going to decrease the amount of radiation that actually goes through in a particular point. It's going to alter it as to what it would be if it weren't there. So that's going to be another thing that we will look at. So you can see here the thin edge of the wedge is aligned with the field border. The center of the wedge is at the beam axis. Depending on how big your wedge is, it could have different consequences whenever you're trying to treat. Combinations of radiation fields. A lot of times when, particularly for emergency or palliative patients, whenever they come in, there are going to be certain arrangements that you're going to run into. APPA, that is an example of parallel opposed fields. In other words, the physician comes in, sees a particular area that they want to treat on a patient's particular volume. Okay, I want to hit that volume. I just want to do it APPA. Let's just make it simple, nothing complex. So you go in, you put on an anterior to posterior beam, and you hit whatever, you draw it using the beam's eye view, whatever the MLCs happen to, whatever that pattern or that aperture ends up being, that's open. And then you take that beam and you flip it around, and that'll be your PA beam, your posterior to anterior beam. That's why they call it APPA, anterior to posterior and then posterior to anterior. And then you're going to be able to treat whatever target is there. You want that target to get a specific dose here. What you're going to see out at the edges is a little bit hotter area that eventually will converge. It'll count down and converge into something here that will cover that particular volume, but will leave certain percentages, higher percentages here out towards the center. So you can see depth of those curves here for parallel opposed fields normalized to the midpoint or midline. In other words, halfway through the patient, whatever that separation is of the patient, you cut it in half, there's your midline. And you can see here that the Cobalt 60, you're going to have some really hot spots out there near the edges. Since we don't treat with Cobalt, the closest thing here that you would see that would probably be the 4 MV. Then as you get closer to 10 MV, you're starting to see these little peaks here start to diminish. And then when you get to the 25 MV, since you have so much buildup away from the surface that you don't really see these peaks like that, you see more of a homogeneous delivery. So when treating with multiple beams, the question arises whether one should treat one field per day or all fields per day. I don't think I have ever run across treating one field per day. But apparently, Wilson and Hall have discussed this problem in terms of cell survival curves. And for parallel opposed beams, they've shown that treating with one field per day produces greater biological damage to normal subcutaneous tissue than treating with 2 fields per day, despite the fact that the total dose is in fact the same. So apparently the biological effect in the normal tissue is greater if it receives alternating high and low dose fractions compared with the equal but medium-sized dose fractions resulting from treating both fields daily. So this is called the edge effect or the tissue lateral damage. Another concept here that we need to talk about is integral dose. One way of comparing dose distributions for different quality beams is to calculate the integral dose, and that is a measure of total energy absorbed in the treatment volume. I'll see if I can dig up a problem or so on this. This is one of the debates that they have regarding using IMRT static fields versus doing rapid arc. What is your integral dose? In many cases for the integral dose, you'll find that it's much higher when you're using a rapid arc because you're covering so much more volume than what you are with the static fields. Number of fields, you're going to find out here that the more fields that you add to something, the more you can concentrate and sculpt the dose there up at a particular volume that's deep in up to a point. And then a lot of times if you try to continue to add more beams or whatnot, then it can become a mess if you're not careful. These are the different types of dose distributions. If you have a 4-field box, generally you're going to end up with something like this. If you tilt these here such that you have a smaller angle here than what you do here, then you end up with the diamond shaped. If you end up with 6 beams not quite off-centered with each other, but fairly close, then you can end up with a shape like this. So isocentric techniques for stationary beams, you can have, these are isodose distributions that you would see here for say a 3-field. So you've got one coming in here and exiting out this way. So it's coming from here, exiting out that way. Then you've got one coming this way and then one coming this way. So you might end up seeing a dose distribution like that where you've got exit dose here, but you got a lot of entry dose from both of these creating a hot spot here. And then you might have a lower level isodose line here, still fairly hot. Then you have one that goes out and encompasses most of the other volume over here. Here you have a 4-field box in which you have dose coming in from anterior, left, right, and posterior. So it ends up creating a little square. And so that's why we call it a 4-field box. Depending on how thick the patient may be in different spots, you may end up seeing, or for that matter, the energy, you may end up seeing some different dose distributions than this. You may end up seeing something like this. It depends, again, on the energy as well as how thick the patient ends up having to be. There's more examples here on rotational therapy. Wedge field techniques. when you start using wedges, I'm going to see if we've got an example here, which apparently right here. If you have two beams, one coming in this way and one coming in that way, you're going to end up with a real high hotspot here that diminishes as you go further into the patient. It's not very homogeneous. Again, your goal for treatment planning is to create as much of a homogeneous field or treatment volume to be able to hit all of your target. And you don't want huge variations in that if you're trying to treat it all at one specific dose. One way to attempt to do that is to put a wedge on with the heels abutting like this and the toes out like this. It pushes these high doses way down here. You might see a little bit here, might see a little bit here. You can over wedge this here if you're not careful, but it tends to push that dose level out like this, so you get a better distribution here. There is something here called the wedge or the hinge angle calculation. If you know what your wedge angle is, and you know, or you may want to find the hinge angle that goes along with that, this is a formula to be able to do that. And I'll try to set up a couple of problems there for you to work through on that. Here is an example of something that you might have seen 20 years ago or more regarding using wedge treatments. Let's say you've got somebody here that's got an open beam coming in this way and may have a wedge here, and this is somebody's head. This is supposed to be an eyeball, I think. You got a spinal cord over here. This is a dose distribution of that, whereas let's say you try a 3-field technique in somebody. So you got their eyes here. So you got an open beam coming in this way. You've got two beams coming over here with 60-degree wedges here on either side. This is normally called a 3-field technique. So you've got the beam coming in here, and then you're trying to push in from the sides in order to not cook the front part of the head. So you push in from the sides, but you also have a wedge here, so you can start pushing that dose further back and get this area treated as well as this area. So here are some designations that I want you to try to remember, because they're going to come up. If you're talking to a dosimetrist and a physicist, these are the kinds of things that you're going to need to be able to discuss when you see targets drawn. You've got the gross tumor volume. So it's the gross demonstrable extent and location of the tumor. You've got so this is GTV, this is CTV. The clinical target volume consists of demonstrated tumor, if present, and any other tissue with presumed tumor. So let's say you've got gross tumor right here, your GTV. This is the stuff that includes the gross tumor plus anything that might be suspected. You've got the internal target volume be added to the CTV to compensate for internal physiologic movements, variation in size, and things of that sort. PTV, planning target volume. PTV is basically going to be, it's going to include your CTV with, again, the IM, the internal margin, as well as a setup margin for patient movement and setup uncertainties. In other words, given all the potential error there for setup and things of that sort, this PTV is generally what you're going to be trying to optimize or plan for. And the margins that you give to create the PTV may be different in different directions. Organs at risk, normally it's OAR. I don't know why it's OR here. These are going to need adequate protection. That's one of the things that the MLCs try to provide. So let's see, you got setup margin, organs at risk. Organs at risk generally outside of whatever this volume is, you're going to end up with certain organs at risk inside the PTV anyway. That's generally how it goes. So those are some important things to remember. You've also got treated volumes here, irradiated volumes, maximum target dose. So the highest dose in the target area is called the maximum target dose, basically what's your hotspot. Minimum target dose is the lowest absorbed dose in the target area. Mean target dose, median target dose, modal target dose. Hotspots. A hotspot is an area outside the target that receives a higher dose than the specified target dose. Normally, a lot of times, we're going to end up calling a hotspot something that may be a little warm, not necessarily above 100%. Sometimes it's referred to that way. But those are different types of things that you can watch for. Okay. I'm going to try to go through and see what I can do as far as creating problems on that. But that's the gist of chapter 11. Major things I would focus on here would be looking at descriptions like this, some of the dose distributions regarding wedge angles, a parallel opposed, maybe even a 3-field or things like that. I'll put some things out there for you to kind of be able to look at, to kind of recognize. Because those kinds of things may end up cropping up on the exam, on your registry. So, and I'll see what I can do as far as putting together problems for the monitor units, because that'll be one of the next things coming up.